All right, so our job here today, what we're going to focus on in this 1 hour session is looking at fluids. We're going to talk about why fluids are important. We're going to talk about how fluids work in the body as far as normal physiology. We're going to talk about the checks and balances that take place for fluids in your body when a person is healthy. And then we're going to talk about what happens when there's disease. Okay, why is it that when a person gets an infection, they swell up and their blood pressure drops? Why is it that a patient who has liver failure swells up, but they have no blood pressure when you take their systemic blood pressure? What are some of those things that change when a person gets sick? All right, so let's start by talking about some of the normal concepts and things that happen with fluid regulation. Okay, and we'll just work off of these. All right, so why is fluid important? That's because we're mostly made of fluid. A large percentage of our body weight is water, is fluid. Okay, so 50 to 60% of the weight that we have is water. And that's even more so in children. And, you know, if you're not aware of that, children dehydrate much quicker than adults do, and so do elderly people. They dehydrate a lot quicker than we do, and it's important that we pick up on fluid imbalances in children and elderly people more rapidly than we do in adults. Okay? They change more quickly. They can exhibit symptoms of fluid volume deficit and overload much more quickly than we do. Now, we're just reminding each other of the calculation conversion that 1 pound of body weight, okay, equals 2.2 kilograms, right? Or 1 liter of water equals, I said it wrong, 1 liter of water equals 2.2 pounds. And why is that significant? Let me give you an example. If you sent your patient off for dialysis for the day, which is a process where they remove fluids and waste products and acid in a person whose kidneys don't work. If you sent your patient off for hemodialysis for the day and they told you, we took off 3 liters, which is common, 3 liters of fluid, what would that mean in body weight? It would mean 6.6 pounds. Can you imagine going in, getting hooked up to a machine, and in 3 hours lose 6.6 pounds? That's not bad, is it? That's not a bad thing. Okay? So when we talk about fluids or fluid volume overload, we can quantify that using that calculation. So let me make sure that I say it properly. 1 liter of fluid equals 2.2 pounds. The same as 1 kilogram. That's what I should have said. 1 kilogram equals 2.2 pounds, right? That's the conversion that you're used to. So in the metric system, 1 kilogram equals 1 liter. All right? So when we get information in the hospital setting, it helps to understand that. So if you're getting a report from the dialysis nurse and she says, oh, it was a good run. I got 5 liters off. What are the risks for the patient if they have a rapid fluid loss like that? Blood pressure. That is the most significant thing that you need to think about. They're losing that much fluid. Their blood pressure can really, really drop. And sometimes we think about, oh, it's just because it's dialysis, they're taking it out of the bloodstream, and so that's a nice correlation. But you could have fluid in your belly. Ascites is fluid in your peritoneal cavity, right? If I were to tap on your belly and you had ascites, it would go woo, 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 like fluid wave. Even if the fluid is in a third space, like your peritoneal cavity, and we tap that and remove it, say we take out 3 liters there, your patient can still experience a drop in blood pressure, even though it's not being taken from the vascular space. Okay, so that's why we care about understanding that 1 liter equals 2.2 pounds. If the patient's having a significant loss of volume in weight, they can experience shifting of fluids, loss of blood pressure, and be very significant in providing adequate care for them. Okay, how it moves. How it moves. It's important to understand some of the checks and balances with fluid regulation. These terms will come up in our next lecture too. You already have that particular picture. One principle of fluid movement is osmosis. This is a principle that we utilize in the body in many different ways. Osmosis is when water moves through a semi-permeable membrane from an area of low concentration of particles to high concentration of particles. The key of your understanding is the particles have power. The particles have pull power. Let me give you some examples of particles that have pull power. These are key concepts that you need to understand through your whole nursing career. Particles with pull: salt, sugar, protein. These particles have pull power. Okay? If the patient is deficient in salt, sugar, or protein, that will affect fluid regulation. If the patient has way too much salt, sugar, or protein, that will affect fluid balance. Most all of you heard about the patient I took care of Sunday who had a blood sugar of 1,240. What is a normal blood sugar? Somewhere between 60 and 120, depending on what book you read. So let me ask you if you can understand this. With a blood sugar of 1,240, what is in that bloodstream? Particles of sugar. So that is a pull power. And by principles of osmosis, water will move from an area of low particle concentration to high particle concentration. So what happened with my patient? Water is moving from his extremities into his vascular space where all that sugar is, and he pees out all the water. You get it? That's osmosis. Now I can use that same principle of osmosis to treat somebody. Let's say that I have a patient who has cerebral edema. Make it simple. Water on the brain, right? I can use particles. I can use mannitol, which is a sugar, and I can give it as a drug, and I can put it in that patient's bloodstream. What am I going to do? I'm increasing the particles in the bloodstream, so what happens? I'm going to pull water from their periphery, from their tissues in their brain, into the bloodstream so they can excrete it. So do you understand why osmosis is so important? And understanding that particles have pull power. What particles am I mostly referring to? Salt, sugar, and protein. They have a lot of power. They're very strong molecules. So this concept can help you understand disease, and it can help you understand the treatments that we use. Okay? It's the same principle. And if you understand it, many of the things that you're seeing in pathophysiology and in treatment will make sense. Okay? Now this other picture is a picture of diffusion. This is a picture of diffusion, where again you have a semi-permeable membrane, okay? And it shows how particles will tend to try to equalize themselves, all right, by diffusion. Diffusion means there's no energy being used, but the particles will try to equalize. So that if you have a high salt concentration inside your vascular space, it will try to equalize into your tissues or periphery. Of the two concepts, which one do I want you to really think about today? Osmosis. You get it. That's really good. I'm glad. That's what I wanted you to be thinking about. All right. Powers that be. And you're going to have to just bear with me because I'm going to put this up so I can draw some pictures for you. Powers that be. Well, maybe I'll let you write that down first, or just think about it for a second. Normal fluid physiology. You have pushing power and pulling power. Your pushing power exerts itself on the arterial side. So let's draw some nice arteries. All right? And let's draw some nice veins. And let's remember what's in between there. What do you think I'm representing in the middle? The capillary bed. Exactly. So we've got arteries. We've got veins. And in the center, we've got the capillary bed. Now, powers that be. In your arterial side, what's behind that is your heart. If you have an inefficient, crappy heart, you'll have to deal with my occasional, redneck expression. If your heart isn't any good, that's going to affect fluid balance. It's going to affect pushing power. Do you understand? Right? If you have not enough volume, that will affect pushing power into the capillary bed. And last but not least, if you don't have enough blood pressure, and it could be for either one of those reasons or some other reason, you're not going to have enough pushing power. The pushing power is defined as hydrostatic. Hydrostatic power is the pressure of the volume against the arterial wall. That's hydrostatic pressure. That pressure is higher than the tissue than the pressure in the capillary beds. So the movement of fluids related to hydrostatic and push power is that those fluids will tend to seep out of the capillaries into the tissues. That is normal. What would happen if the blood pressure got really high? That would increase hydrostatic pressure. What would happen to the amount of fluid that's pushing into the capillary bed? It'll increase. And what will be the net movement of fluid in the capillary bed? More of it will go into the tissues. That's correct. That is why when you have a patient who has a really high blood pressure, especially if they have a bad heart, they're going to go into pulmonary edema, because fluids and that high blood pressure is going to seep out of the capillaries in the alveoli and end up in the lungs. Do you get it? How can we affect change? Lower the blood pressure. That will stop the shifting of fluids and make it easier for the heart to do its job. So I'm giving you a disease example there, right? Now on the other side, you have pulling power. You have pulling power, and that's primarily handled by proteins. You are going to learn a lot about my favorite protein, albumin. Albumin is the primary reason that fluids come back into the vascular space on the venous side. Albumin provides pulling power. What if your albumin is low? You're in trouble. Is fluid going to come back into the vascular space? No. What organ in the body makes albumin? Very good. Usually my Block 2 class can't answer that. It's kind of like, ooh. It is the liver. So, If you're taking care of a patient who's in liver failure, what do you think happens to their fluid balance? Where does all their fluid stay? In their tissues. Excellent. You get it. It's as simple as that. So let's make sure that we all understand. Let's go back to the beginning. The powers that be. All right? On the arterial side, we have pushing power or hydrostatic pressure. That has to do with the volume pressing against the vascular walls. That is provided by the heart, how much volume you have, okay? It may be low, it may be high, and the resulting blood pressure. If all of these parameters are healthy and in check, you will have the normal amount of hydrostatic pressure going into the capillary bed, the normal amount of fluids going into your interstitial tissue, providing nourishment, electrolytes, the facilitating movement of oxygen, and etc., right? On the venous side, you have pulling power. What provides the pulling power? Protein. That is the main key feature. Okay? And as long as we have adequate albumin and protein, the fluids that are in the interstitium will come back into the vascular space. Shy a little bit. And that which is not pulled back in is supposed to be shuttled back to your heart via the lymphatic system. Okay? The lymphatic system. Closed channeled tubes that are down in your tissues that seep fluid and bring them back to your heart. You heard about those before? Okay. That's it. That's normal fluid physiology, the powers that be. If you understand that, you're way ahead. You're way ahead. Any questions about that? Did you draw it? If you draw it, you'll probably remember it better. And if you put color on it, if you don't have color, when you put color on it, you'll probably also remember it better too. Okay, now we're going to talk about a couple of terms that tend to confuse people. You do not have to memorize these definitions. Are you glad?
Yes.
What you have to understand is the concept. You with me? Okay. We're going to review the definitions. Osmolarity refers to the particles in a type of solution per liter. Osmolality refers to the particles in a solution per unit of water. Do you think I have those memorized? I've been a nurse for a long time. I don't need to have those memorized because the bottom line is how many particles in the fluid compared to me? That's all that really matters. Osmolality and osmolarity is just a comparison of how much particles are in the fluid. That's all it is. So don't make it hard for yourself. We use that knowledge and that understanding to treat patients. All right, so what's osmolality or osmolarity? It has to do with how much particles are in fluid. We compare that to serum, plasma, the human body. Does that make sense to you? I hope. Do you have to memorize those words? You have to understand the concept. You probably had to memorize them in, what class would that be? Chemistry, something like that. I assure you I don't have them memorized. That concept of how much particles are in fluid brings us to these terms, which you need to understand. How many particles are in fluid compared to the human body. So let's just talk about for a moment the prefixes on the word. Hypo means less. Iso means same. Hyper means more. Tonicity is the same concept as osmolality and osmolarity. It has to do with how many particles are in solution compared to the human body. I go slow through this because I don't want to lose anybody. Right? So, if I refer to myself and say I am in an isotonic situation, what am I saying? That at this particular point in time, the amount of particles that are in my bloodstream compared to the fluids is within a normal range. What we would look at for labs would be serum osmolality and serum sodium. And possibly, if it's out of range, what's the other particle? Sugar. Proteins or sugar, if they're out of whack. Okay? Primarily, when we look at tonicity in a person or what they're doing as far as fluid volumes, we're looking at sodiums and we're looking at serum osmolality. Those are the two values. So, if I am in an isotonic situation, my sodium would be within 135 to 145. That's an isotonic patient. I'm not going to make you memorize serum osmolality. If I refer to it in this semester, it will either be high, normal, or low. I would like you to know serum sodium levels. That's kind and gentle. You've been exposed to those already, right? 135 to 145. So if I'm isotonic, we can assume that my sodium level is probably, 140, something in the normal range, and my serum osmolality is normal. All right. Now, what will change if I, as a person, am hypotonic? What does that mean? It means that there is more water compared to the amount of particles in my body. Hypo. That's right. I'm going to give you a handout in just a minute. I want to go through it in your mind first, then I'm going to give you a picture. So if I am a person and I'm hypotonic, that means that there's more fluid in me than there is particles in my vascular space. That's how it's measured. It's measured in your vascular space, not in your tissues. We'd have to be sticking interesting catheters down into people's tissues to measure that. All we can truly measure is the serum, the vascular space.
So a renal patient is going to usually be hypotonic before dialysis?
Correct. A renal patient will be hypotonic before dialysis. And you will experience other things, like in the diagram that we talked about. Because they retain fluid, what happens to their blood pressure? It goes up. Because their blood pressure goes up, what will you see happening in the capillary bed? More fluid will go, and the patient will develop? Correct. Correct. If the patient also is malnourished and has a low albumin, they will have more and more. Correct. That's an excellent application. Hopefully that makes sense. Now, let's talk about ISO. We did hypo and ISO. We need to do hyper, right? Okay. What does hypertonic mean in a person? It means that we have more particles in us than we should compared to the amount of body fluids. So if we were going to look at labs, we would see that the serum sodium is high, and the serum osmolality would also be high. And those go together. Okay, osmolality and serum sodium go together. All right.
Sodium, you said?
Serum sodium. All right. I want to pass out a form for you because I want to take it to the next step. I want to move us from looking at the patient and tonicity and look at the patient and IV fluids with tonicity. Are you still with me? So let me pass this around. Because we use the same terminology to describe IV fluids as we use to describe a person. And that's where there's confusion sometimes, because the doctor may make a note that the patient is hypertonic. The patient is hypertonic. Or he may make a notation that he's using isotonic fluid resuscitation. That term can be used to describe a patient or a therapy. It's just a term. If you understand what the term means, then you can apply it to whichever application it's being used in. Yes? Okay. All right. Up on the top box, we are do you have them all yet? Everybody have them? Do you have any questions while the forms are going around? Any clarifying questions? Anything that's not making sense so far? These are difficult concepts. They're very difficult concepts that people have a lot of trouble understanding.
I have a question. So when I take notes, I try to think of how a test question would come out of that. So like pushing power and pulling power, would it be basically, I mean, you said draw that, color it, and everything. I'm trying to figure out how a question would come out of that. Does that make sense?
She's asking me how I might formulate a test question related to pulling and pushing power. I would be more likely to cache it in a patient scenario and say, which of the following factors contribute to the development of edema in a renal failure patient? Excessive pushing power or hydrostatic pressure, not enough hydrostatic pressure, too much pulling power or not enough pulling power. Okay, something like that.
Okay.
So that I would be wanting you to identify that it is the fluid retention and the high hydrostatic pressure which causes the development of edema. That would be a pathophysiology question related to fluid shifting in disease.
Thanks. Got it.
Does that help?
Yeah.
So we'll cache it in a scenario, but hopefully you're going to get some of those examples in application.
Could you touch on hydrostatic one more time?
Hydrostatic, the definition has to do with the fluid pressure on the artery walls. So as the fluid comes into the artery and into the capillary beds, that the pressure that's exerted from the fluid on the wall of the artery is described as hydrostatic. Hydro usually refers to water, but I'm referring to it as, the blood volume to everything. So the water pushes against the surface of the artery. When it comes down into the capillary bed, those are single cell walls. So there's shifting that occurs in the capillary bed. There's only single cells there. So if the pressure is really high, the pressure of the volume against the capillary walls, more fluid's going to go out. Does that make sense? The same thing as if you had, water in a balloon or something, and you're squeezing it tighter, more of it's going to, seep out if you puncture holes in it or something. It's.
Okay, thank you.
All right. So this is an attempt to help understanding in students and in, staff nurses like these too, to improve understanding of concepts related to fluids and osmolality or osmolarity. Okay, so in the first box, there's definitions of osmolality. You do not have to memorize those. But there's some numbers that are attached to osmolality. Less than 275 milliosmoles per liter, hypotonic. Isotonic between 275 and 295. That would be a normal serum value in os, an isotonic patient. Correct. Okay? Hypertonic, greater than 295 milliosmoles per liter. More particles in solution compared to normal. All right? Let's use that for just a second, even though I'm not going to test you on it. If a patient has a serum osmolality of 320, that patient is hypertonic. If a patient has a serum osmolality of 260, that patient is hypotonic. An understanding of that helps you be able to clarify if patients are receiving the right types of IV fluids, the right types of treatments based on tonicity. There are a lot of other factors too. All right, the second row talks about what happens to cells if we give the patient a hypotonic, isotonic, or hypertonic fluid. The next line talks about what happens in the blood vessels if we give the patient a hypotonic, isotonic, or hypertonic fluid. Okay, so I'm shifting from the patient to these next lines as to what happens with IV fluid. I'm going to start in the middle. Iso means same. If you give a patient an isotonic fluid, such as normal saline, that fluid will tend to stay in the vascular space and not go into the cells. And we're assuming, of course, that the patient has a normal salt level, sugar level, protein level. You're following, okay? So if we give a patient an isotonic fluid, it tends to stay in the blood vessel and not go into the cell. Do you get it? Okay. If we give the patient a hypotonic fluid, meaning that it has less particles in it than the body, or we say it the other way, it has more fluid in it compared to particles than the human body, the fluid will tend to leave the vascular space and go into the cell. So you could just draw more arrows across this right over to there if you want to, if you're very visual like I am. So that is the most dangerous fluid we give, a hypotonic fluid. Why? Because it tends to leave the vascular space and go into the body cells. If you have a doctor that orders D5W, which I know is listed as isotonic, but guess what? The sugar gets used up really quick and all you're really giving them is water. There are some doctors who order D5W 150 cc's per hour on every patient they admit. What if it's an old grandma who has CHF and has renal insufficiency? Within an hour or two, her clear lungs will be full to the brim. Do you see why an understanding of fluid physiology is really helpful as a nurse? Really helpful? That is dangerous. Very dangerous. What types of patients do you think will benefit from that? Patients that are dehydrated. So let me put it to you this way. Can you understand that a patient that is hypertonic may well benefit from IV fluids that are hypotonic? Does that make sense? Fantastic. We're getting somewhere. Fantastic. Okay. Now let's look at a hypertonic IV solution. D5 normal saline, D5 half normal saline, D5 lactated ringers, D10W, dextrose 10% W. Those have more particles in them in relationship to fluid than the human body. If we give a hypertonic solution, what will tend to happen is that fluid will move out of the cells and into the vascular space. So draw your little arrows from one to the other so that you understand the shifting of fluid that occurs when we use a hypertonic solution. What types of patients might benefit from this type of solution? Perhaps someone who has low blood pressure, as long as they're not coding. If we have somebody with a really low blood pressure, we want to give them fluid that's going to stay in the vascular space right away. And incidentally, this is what you're going to see them use in the field always, is isotonic. Okay? Let's say we have a patient that's recovering from surgery and they have edema. Their blood pressure's good, they're doing fine, but the doctor is interested in facilitating the mobilization of fluids out of their tissues so they urinate it out. That's a lot of times when you're going to see a hypertonic. Would it be appropriate to give a hypertonic patient a hypertonic solution? Thank you very much. We need to teach the physicians that. The tissues may already be dried up. We're not going to be able to pull anything extra out of them. Okay? So do you kind of understand a little bit more now, possibly about tonicity? Okay, let's go back to the very beginning. Okay, back to the very beginning. Normal fluid regulation depends on push and pull powers, yes? What creates the push? The creation of hydrostatic pressure. The heart, volume, blood pressure, those are all things which create hydrostatic pressure. We need enough hydrostatic pressure so that fluid will go into the tissues. What goes with fluid when they go into our tissues? Nutrients, oxygen, electrolytes. What is it that pulls that fluid back into the venous space? Protein. Specifically, albumin, which is created by the liver. I love albumin. I love it. I do. You'll hear me talk about it a lot in class. Very, very important. So, do you understand the powers that be? Okay. That's what's happening as far as fluid balance occurs. All right. Osmolarity, osmolality, tonicity. They are all terms which refer to the amount of particles in solution or fluid. Do you need to have them memorized, the definition of that? I'm not going to ask you that on the test. You need to understand the concept. Okay? 3 words. Hypotonic, isotonic, hypertonic. Those words can be used to describe a patient or an IV fluid. If I say a patient is hypotonic, would you say that that patient is in fluid volume overload or fluid volume deficit? They're in fluid volume overload. That's correct. If I was telling you that your patient's dehydrated, is that patient in fluid volume overload or fluid volume deficit? And that patient will be referred to as hypertonic. Good. Now, if you were taking care of a patient that's hypertonic, you would expect that they would be receiving IV fluids that are hypotonic or isotonic. The main key factor that they look at is blood pressure. If I need blood pressure support, they will be receiving isotonic. The only time when this really doesn't work is if they have a low albumin. If I'm taking care of a patient who has low blood pressure and they also have a low albumin, will there be anything to hold the fluid in the vascular space? You need to know that. The doctors order fluid challenges all the time for hypotensive patients who have no albumin. It's very frustrating to me. Liver failure patients lose their blood pressure a lot, right? They have no albumin, they don't make it, their fluids end up in their belly.
So why don't they hang albumin for fluid?
I don't know. I even asked for it by name. 500 cc fluid challenge, stat. That means I'm going to give 500 cc's as fast as I can give it to bring my blood pressure up. That's called fluid resuscitation. What do I expect to happen? I'm giving a fluid that will tend to stay in the vascular space. That should make blood pressure go up.
Because you increase your pushing power.
That is correct. However, if the patient has a disease like liver failure and they don't make albumin, what will happen to all of the fluids? They're going to seep right out and fill up the belly even more. So, word to the wise, you got a liver failure patient with no blood pressure, what you want is albumin. Questions? I'm trying to say it like 10 million different ways so that hopefully the key concepts come across. A diabetic. All right? Let's talk about some disease processes, and we'll start with that one. A diabetic tends to have an abnormality. What is that abnormality? They have issues with high blood sugar. Sugar is a particle. It is a particle that has a lot of pulling power. So, if we have a patient with an elevated blood sugar, what is going to happen to fluid regulation? They're going to be a hypertonic patient. And what we've done, I mean, I showed you albumin on the venous side. But what we've added to that now is lots of sugar. So not only are we going to pull back the normal amount of fluid, we're going to pull back every stinking drop they have. And where will all that fluid go? Through their kidneys? Well, let's just think about it for a second. We pull the fluid into the vascular space. That's going to transiently increase the blood pressure. That's going to perfuse the kidneys. The water's going to go out, right? And it's going to keep happening until there's no more fluid to pull. Then what happens to your patient's blood pressure? It drops, and your patient will go into shock. That's what happens with a really high blood sugar. We lose all of our fluids, they go into shock, they get hot. We don't have enough fluids, we get hot. We have too much fluids, we get cold. There's a correlation between fluid volume status and temperature. You get somebody that's really dehydrated and sick, as you get them rehydrated, their temp's going to come down a little bit. You didn't know that.
This might be a stupid question, but if you have a patient that's diabetic and has like fluid overload, so they're having two opposite things, what do you do?
Well, this would be the issue. You can have a patient that's diabetic that also has CHF. What's going on with their blood sugar is the question. We would not use sugar to treat the fluid imbalance in a diabetic patient. That would be contraindicated. We will always seek to normalize their blood sugar so that that's not a factor. And if we have a patient in fluid volume overload that's diabetic or anything else, we need to get rid of fluid. We need to get rid of fluid. So what would we use to get rid of fluid? Diuretics. The only other way we would be able to affect that is to stop giving them fluid. We'll do some application exercises in our next session where we'll talk about just that very scenario. Given this disease process, is this the right IV solution? Given this disease process, should they get an IV solution at all? So we would have to ask ourselves, you know, what's the relationship of the blood sugar to the fluid volume status. If the blood sugar gets high, the patient dehydrates because sugar is an osmotic diuretic. It's an osmotic diuretic.
So that's why the patient will always be so thirsty.
Yes, that is what creates the polydipsia. The I am so thirsty, because they are a hypertonic patient if their blood sugar is high. Write that down. Sugar's an osmotic diuretic. Mannitol. Remember I was talking about using particles for pharmacological treatment. Mannitol is a drug. It is sugar. Same principle. Your patient has a really, really high blood sugar. It works as an osmotic diuretic. Osmotic has to do again with particles. Particles that have pull power. And you know what diuretic means. Drug that makes you pee. Osmotic diuretic. That's what a high blood sugar is in a patient. Even though it's pathological, it works the same way as if you were going to give a drug to get fluid out of somebody. Does that make sense? See, so many of these concepts thread through. If you understand the key concept, you'll be like, oh, you look up mannitol, osmotic diuretic. Osmotic, particle. Diuretic, pee. Particle that makes them pee. Well, that's all it is. I'm just here to help those big words that are overwhelming make a little bit more sense to you. And whether it's a drug that I've given to them that increases the particle in their vascular space, or their disease process that increases the blood sugar, that's yet to be seen. Now, you're bringing up a diabetic that's in fluid volume overload. Is it possible that you could have a patient with a fairly high blood sugar that's in fluid volume overload? Yes. But that has to do with some other pathophysiology that's going on inside of them. Maybe they're in renal failure and they hold every drop of fluid basically that gets into them until they have their next dialysis treatment. They're not going into fluid volume overload because of their diabetes. And even if they have a high blood sugar, they're not going to pee because their kidneys don't work. So you have to kind of interface all the different disease processes and sift it out. What came first, the chicken or the egg? Or what is the disease process that's in charge right now? And how do we calm it down? Does that help? Other questions?
I'm like, for some reason I keep thinking about sodium, and you know how like when they say you eat like a lot of salted potato chips, you swell up. But if you have a high sodium, then all fluid's going to be drawn into the vascular space. So how do you swell up if all the fluid's in your vascular space?
Let's answer that question. Okay, so the question is, when you eat lots of chips, which I love doing, Cool Ranch Doritos, please. When you eat a lot of chips and you eat a lot of salt, you swell up. How does that happen? Okay, so you eat a lot of salt, right? That's going to hold fluid, period. When you hold fluid, your blood pressure goes up. When your blood pressure goes up, that increases hydrostatic pressure. And when you increase hydrostatic pressure, the fluids go out into your tissues. Now, you have healthy kidneys, I hope. And healthy kidneys will start expelling that salt right away. So it's not like you're dehydrating yourself for the most part. But your body is going to think, oh my gosh, my serum osmolality is high. Right? Your hypothalamus is right on that. Your hypothalamus is right on that. And your posterior, all these things are happening. And what will happen is your thirst center is going to go, man, I'm really thirsty. So not only are you taking in the salt, but you're also taking in the water. You're normal.
Pushing out the tissues.
Yeah.
But if you have a regular albumin level, it should pull it out of the tissues.
Well, there's going to be an imbalance for a while. Nobody's supposed to eat a whole bag of Cool Ranch Doritos. That's not right, you know. Be the same thing if I decided to dump a bunch of salt into you with an IV solution. Okay?
Yeah, but then you're drinking it with that big liter of Coke.
Yeah, and you're drinking it with fluids. Most of the time, a normal person is going to eat all that salty stuff. High osmolality, you'll equalize it yourself by drinking water.
But if you're drinking it with Coke, right, isn't again because of the sugar? I mean, you're getting
your body's gonna want to pee that out too.
Well, I'm not sure I can explain perfectly, like if you eat a bag of chips and then you have a soda and then you drink water and then you do this and then you stand on one leg and jump up and down. The main thing is that you understand the principles. That if you dump a bunch of salt into yourself, well, your body is normal. It's going to say, holy cow, I am really concentrated. Water! Water! Your body will seek balance on its own. So you eat the salt, you drink the water, your blood pressure is going to go up. You're going to spill some of that tissue, that fluid into your tissue. You'll start expelling water, probably the next day. But it'll seek to equilibrate first, and your pressure will go up, and that's kind of the way it works. Does that help?
Yes, it does.
Okay. All right, any other questions?
Is that why albumin is then so important because it does not go out?
Yes, that's why albumin is so important. Albumin is a large particle, and it tends to stay in the vascular space. It's not one that's shifting in and out. So it's very important because it pretty much lives in the vascular space. And if we were trying to restore albumin, we could either give albumin or we could give fresh frozen plasma. Fresh frozen plasma is what remains from your blood if you pretty much get rid of all the cells. Fresh frozen plasma is a large percentage of albumin. But yes, it's a large particle and pretty much stays in the vascular space. It doesn't get filtered through the kidney. It's too big. So sugar, they're too big. They're never supposed to be in your urine. They're large particles. Good point. Very good point. Albumin's a carrier, right? Did you learn that last semester? It carries certain things, drugs and other things. It's a large particle. Same with sugar. Too big. It should not be going through your glomerulus and ending up in your urine. It's abnormal if you have sugar and albumin in your urine. They're not supposed to be there. The only way they get there is if the glomerulus is damaged, or with sugar, you have to have a really, really high concentration. And then that starts causing damage. We'll talk about that in renal. Yes?
So is the albumin eventually broken down into simpler particles, or is it excreted through the intestines?
I'm not sure I can answer that as far as the life cycle of an albumin molecule. I don't know. He's asking me about how it gets processed or excreted, or not really sure. I just know if we don't have enough, we're in a bad way. And it's critical to fluid balance. And we'll have to check into that as far as the life cycle. I know that it needs to be replenished. I know that its half-life is about 20 days. I know that. And I know that if you don't have adequate nutrition, you also won't make enough albumin. The two key factors that are usually associated with low albumin in hospitalized patients are liver failure and malnourishment. Okay? That's about probably all I could tell you. I can't really answer that other question. It's very hard to get that level to come up in a patient if it's low, because the half-life is long. It takes a while to replenish it in a patient, so that's why we usually dump it in.
In the IV fluid that we have in each of the areas, I know they have, the saline has the salt. Are there any of the IV fluids that actually have albumin in them?
As far as the standard IV fluids, no. None of the crystalloid solutions that are listed here, which none of them have albumin in them. The only way you're going to be giving albumin to a patient is to give them albumin, either 5% or a more concentrated 25% or fresh frozen plasma. Those are the ways that we give somebody albumin. There is no other way. Good question.
So isotonic fluid, normal saline is an isotonic fluid. What does lactated ringers have that normal saline does not have to make it an isotonic?
Good question. And you can look these up in your book also, but let me give you some ideas. A lactated ringers has buffer type solutions, like I'm trying to say bicarbonate. It has potassium. It is supposed to provide similar electrolyte content that your body would, but ends up having other components too. There's a list of things that are included in that. It ends up having more particles than body solution. The lactate piece is a buffering type concept when I think about lactated.
So it's more of an electrolyte fluid.
Yes. And many of the doctors like using that.
You'll see a lot of patients come back from surgery with lactated drinks.
Right, D5LR is common. Just so you know, as far as a 1 liter bag of IV solution, if it's D5, you're only getting about 100 calories out of that bag. You know, so many of the patients will point to the bag and say, that's my food. It's really not. It's really not at all. They're only getting maybe 100, 150 calories out of 1 liter of dextrose 5%, regardless of whatever else is in it. So, you know, I don't get to hit you hard on the nutrition concept right now. But basically, most of our hospitalized patients eat themselves while we take care of them. Not much calories in a bag of dextrose 5%. If it's dextrose 10%, okay, they're going to get maybe 300 calories. Early nutrition. Or they're going to drop their albumin levels. And then they're going to end up looking like malnourished children in third world countries. And they look just like patients with liver failure. The big belly, ascites, a little bit of swollen ankles, stick arm and legs. I'll try to draw the correlations where I can for you to help you understand. Okay? Did you learn anything? Yes. Did you feel that was helpful? Yes. Okay, very good.